So once the patient is discharged from the hospital or discharged from home health PT or sometimes outpatient PT, they're ready for outpatient cardiac rehab. That's often based in a hospital, but it's an outpatient setting, and it's a monitored exercise program. So cardiac rehab, we do the early phase 1, in the hospital, in a subacute setting, in home health, or occasionally in outpatient if the person isn't ready to go to cardiac rehab yet. They don't have the activity tolerance to be able to tolerate it. Sometimes I have worked with people in outpatient to get them ready for cardiac rehab. In general, though, if the person meets all those requirements and they're 2 weeks post-procedure, they go to outpatient cardiac rehab for monitored exercise. So the activities or exercises of an intensity of 3 to 4 METs, and a MET is a metabolic equivalent. So it's generally considered 1 to 2 METs is sedentary activity, very little energy expended during that. Light activity is considered light housework, cooking meals, doing things like that is 2 to 3 METs. 3 to 4 METs is like walking, moderate exercise, and that's kind of what we're doing in phase 2 cardiac rehab. And then above 4 is considered vigorous exercise, and so that's, you know, running, sports, etc. And they can get higher up to about 10, which is like really intense physical activity. So usually at an intensity of 3 to 4 METs, you can carry on a conversation, but your heart rate is up a little bit. At higher, above 4 METs, you are breathing a little heavy. It's difficult to carry on a conversation. That's what, for a healthy person, is generally considered the aerobic phase. And then more vigorous exercise is where you can't carry on a conversation. Your heart rate's really high. So besides the cardiac exercise in cardiac rehab, they also do range of motion exercise with gradual increase in speed, duration, or with light weights. So generally, in a session, they'll do 2 20-minute sections on different exercise machines, stationary bikes, new step, sometimes treadmill if the patient can tolerate it. The early ambulation is sort of a slow stroll, which is 1.5 to 2 METs. A regular slow walk is 2 to 3 METs. Propelling a wheelchair with their feet can be 2 to 3 METs. I have some charts that I'll share with you of different activities and the METs involved with them. So strength training is also included in cardiac rehab because muscular hypertrophy, the good kind of muscular hypertrophy from exercise, increases efficiency of mitochondria, and they become more efficient and they reduce work stress on the heart, which yay. So cardiac rehab phase 2 generally consists of 24 to 36 sessions, usually 3 a week. It's 8 to 12 weeks long, and education for the patient. Education on a lot of different things, and we'll talk about that. So the real emphasis in cardiac rehab is on independence with the patient. So it's monitored exercise. The patient comes in, they put on their monitor. There are exercise physiologists monitoring their heart rhythm and their vitals throughout the session, making sure that they are not exhibiting signs of exercise intolerance, and providing education. So generally, the patient comes in, they put on their monitor, they start in with their exercise, they finish their exercise, and as they're stretching or cooling down or doing strength training, there are education sessions. And every patient that I've talked about who's been to cardiac rehab has reported very positive response to it. It's a very supportive, encouraging environment, which is great. It's really helpful for having people meet their rehabilitation goals and continue on with a healthy lifestyle. So in phase 2, the exercise physiologists are doing exercise prescription. And so the frequency is 3 to 5 times per week. Intensity is between 50 to 85% of the VO2 max. And we'll talk about that in a minute. The time 20 to 60 minutes. And the type of exercise is aerobic and large muscle group exercise. So VO2 is the maximal oxygen consumption of the whole body, and primarily by skeletal muscles, but it's the whole body's oxygen consumption. VO2 max is your aerobic capacity. So as the workload increases, VO2 increases linearly until it plateaus, and that plateau is your VO2 max. So it can be measured. It's usually in the laboratory. It's measured, with, you have a face mask and you're running on a treadmill. That is not usually done in cardiac rehab or in physical therapy. And so we'll talk about other ways that we determine someone's aerobic capacity. But, generally people in cardiac rehab are not going to probably tolerate VO2 max measurements. And they're not doing stress tests there usually either. So the exercise considerations for phase 2 of cardiac rehab, the patient needs to be exercising 4 times per week for 35 to 45 minutes with a heart rate max of 60 to 85% or 60 to 85% of their capacity, or measured by a rate of perceived exertion scale if they're on meds that regulate heart rate. And we'll talk about that. They need to be able to exercise submaximally to remain below their myocardial oxygen demand. And we'll talk about that in a minute too. So the heart rate times the systolic blood pressure is what gives you that myocardial oxygen demand. And so we don't want people exercising at their max. We want them submaximal, so we can slowly push that threshold up. Post-operative patients need low intensity frequent sessions and a heart rate increase of no more than 10 to 20 beats per minute above their resting heart rate. So being closely monitored is really helpful for that. Plus, it helps them learn what their threshold is, what their level is. So this is the oxygen consumption relative to exercise intensity. As exercise intensity increases, oxygen consumption increases linearly until it reaches your VO2 max, and then it plateaus. So when they're measuring it in the lab, they can measure that. And usually they do that with performance athletes and things like that. It's not usually done in cardiac rehab. Normal exercise response is an increase in VO2, so an increase in oxygen consumption throughout the body, which makes sense. An increase in heart rate, which gives you the increase in cardiac output. Increase followed by a plateau of stroke volume. Increase in respiratory rate, and an increase in systolic blood pressure. The diastolic blood pressure should stay stable during normal exercise response. The maximum rate of oxygen consumption is usually measured on a motorized treadmill. So that's like the stress test. And VO2 is the oxygen consumption throughout the body. Signs and symptoms of exercise intolerance, we should really make note of these with our patients. So if someone has moderately severe angina or increasing angina, chest pain, stop exercising. If they have marked dyspnea or difficulty breathing, lightheadedness, dizziness, or ataxia, which is incoordination, cyanosis, which is a blue tinge to the face, or pallor, paleness, they're not getting enough oxygen, excessive fatigue, or leg cramps or claudication. So if any of these things are happening, you need to stop exercising. So these are things that we can measure without, these are basically all symptoms that either the patient's going to report or signs that we can see without an instrument. With measuring with instruments, measuring blood pressure mainly, if the systolic blood pressure doesn't rise during exercise, that is an abnormal response. If you get hypertensive blood pressure response, so both the systolic and the diastolic rise, that's abnormal. Progressive fall of systolic blood pressure is abnormal, or a change in the cardiac rhythm. So we are not going to know the change in the cardiac rhythm unless you're in a setting where the person's on telemetry. But those other things are abnormal responses to exercise. The other things that limit intensity, the anginal threshold. So people that have angina, stable angina, usually know what level of exercise is going to set off their chest pain. If they can stay below that, you can actually kind of nudge it up as you go along. So if they exercise below their anginal threshold, so exercise to the point where you can without getting chest pain, basically. If you have a decrease in systolic blood pressure with exercise, you want to keep your intensity really low. ST segment depression of greater than 1 millimeter, and that is something you're only going to know from an EKG, so we generally won't know that. If someone has a blood pressure of 240, greater than 240 over 110, limit that intensity. Sometimes if somebody comes into outpatient and they have an excessively high blood pressure, I will either suggest that they discontinue the session and call their doctor, or if they want to continue with the session, we're going to do lying down low intensity things. Cardiac wall motion abnormalities are detected through echocardiogram or nuclear scan, and so we're not going to know about that unless the cardiologist tells us. Or significant EKG disturbances, and again, we're not going to know about that. In cardiac rehab, they will, but we won't know about it in physical therapy. So exercise intensity is the percent, when we talk about the percent maximum heart rate versus percent VO2 max, they're equivalent basically. So the percent maximum heart rate is equivalent to the VO2 max, and the percent heart rate reserve is equivalent to the VO2 reserve. So how are we going to determine maximum heart rate? There are different ways to do it. One way is the clearance heart rate, which is the clinical maximum attained on a stress test. In cardiac rehab, they don't do stress tests usually, but they'll do it in a cardiologist's office. Most of the people who are doing cardiac rehab probably wouldn't be able to tolerate a stress test at that point. But if you have that clearance heart rate from a stress test, you can calculate their target heart rate range by the clearance heart rate times 0.7 is the beginning of your range, and the clearance heart rate times 0.85 is the end of your range. So exercise intensity for a cardiac patient is 70% of max heart rate attained on a stress test. So if you have that clearance heart rate, you can use it as your calculated clinical maximum heart rate. If you don't have that, if you have a healthy patient, well, it says they're a health patient, but if you have a healthy patient, you could do 70 to 85% of their predicted age-adjusted maximum heart rate, which is just 220 minus your age. So that's for a healthy patient. A more accurate way to calculate the target heart rate range is using the heart rate reserve. So the heart rate reserve is used to describe the difference between a person's measured or predicted maximum heart rate and the resting heart rate. So the heart rate reserve is the maximum heart rate, however you determined it, minus the resting heart rate. In order to support myocardial oxygen demand, particularly during times of increased oxygen demand, like during exercise, the heart has to extract oxygen from the arterial blood supply supplying the myocardium. So the heart needs a lot of oxygen. That's why it has that extensive coronary artery system. So our heart rate reserve is our maximum heart rate minus resting heart rate. The Carbonin formula is another way to calculate your target heart rate. There are calculators that you can find online and just enter in your numbers and it calculates it for you, which is kind of nice. You can, however you calculate your maximum heart rate, you can use your heart rate reserve to get your target heart rate. If someone's on beta blockers or some other medication that is keeping their heart rate low, then you have to use a rating of perceived exertion, which is a subjective rating scale related to exertion. So we have a couple, the Borg rated perceived exertion scale was the original one, and it goes from 0 to 20. There's a modified one that goes from 1 to 10, which people seem to have an easier time quantifying 1 to 10 than 0 to 20. I don't know why, but I have printed copies that you can look at and save and keep. So rated perceived exertion is something that you always have with you, and it's a good thing to educate your patients about rated perceived exertion, because then they don't always have to stop and take their heart rate or something like that. They can tell how hard they're working if they tune into how to do that. So that's an important thing to teach your patients. And in our clinic, we have, like by the treadmills and stuff, we have little signs up that give little measurements for rated perceived exertion so people can look at those. Other considerations for exercise: if people have peripheral artery disease, a lot of times it hurts when they walk. So you want to walk until it hurts too much, and then you rest, and then you walk some more. So with chronic obstructive pulmonary disease, you want to educate them on pursed-lipped breathing and energy conservation. Strength training is important to help everything work better and maximize your oxygen use, because you're strengthening your mitochondria. People with mobility deficits, like they use a wheelchair for mobility. You can use an arm ergometer, seated equipment. A lot of equipment has removable seats, so you can just roll up to it with a wheelchair and use the arm and leg attachments for that. So just because someone has a mobility deficit doesn't mean they shouldn't be getting cardiac exercise. In fact, they should be getting cardiac exercise. But just remember that patients rarely come in with a single issue, and it's our responsibility to develop an exercise program that maximizes the benefits of cardiac rehab in the safest possible manner. So, and that goes for all rehab, not just cardiac rehab. It's our job to be creative and come up with ways for our patients to get the exercise that they need. So contraindications to exercise: if your blood pressure is greater than 200 over 110, you should not be exercising. That's a reason for terminating the appointment. If your glucose is above 400 or above 250 with urinary ketones, or less than 90, you shouldn't be exercising. And I have actually seen those show up on practice exams for the board exam, the glucose and blood pressure contraindications to exercise. If someone has a new EKG rhythm that they haven't seen before, and of course that applies more to outpatient cardiac rehab than it does to physical therapy, because we're not going to usually see that. But these days with implanted insulin pumps, a lot of people can just look at the app on their phone and know what their blood sugar is right then. Or a lot of people take their blood sugar right before they come to PT. If you work in a hospital or skilled nursing facility, usually nursing is monitoring people's glucose, blood glucose level, and so you have that information available to you right then. So those are important things to think about before we make people exercise. One of the things that we educate people about in cardiac rehab and just in general is risk factor modification. So there's some cardiac risk factors that you can't do anything about. They're non-modifiable. So if you have a family history of cardiac disease, and it doesn't mean like just somebody somewhere in your family has cardiac disease, but if a close male member of your family died of heart disease before the age of 55, or if a female close family member died of heart disease below the age of 65, then you have a family history of heart disease. If you're male and you're over 45 or female over 55, then that's a non-modifiable risk factor for heart disease. Estrogen is considered cardioprotective. So once women go through menopause, they quickly catch up to men in their cardiac risk factors. Unfortunately, there are a lot of modifiable risk factors: cholesterol level, hypertension, smoking, being sedentary, diabetes or metabolic syndrome, stress, and obesity. So obesity is considered a BMI greater than 30. So those are all modifiable risk factors. We can educate people on medication. Really, medication is not our wheelhouse in physical therapy. And so usually when people ask about their medications, I will say, follow your doctor's directions. Make sure you take your medication on time. If you're having a reaction medication, contact your doctor right away. So we can educate people in that manner. We're not recommending or prescribing medications or changing people's dosages, but we can help them adhere to their doctor's instructions. Nutrition is also not in our wheelhouse in physical therapy, but we can make recommendations to people about when they should seek assistance. So why should anyone do cardiac rehab? That's a good question, right? So one of the things about cardiac issues is they don't have physician follow-up really frequently. After they're out of the hospital from their procedure, they usually have a follow-up visit in a month, and then 3 to 6 months, and then annually. So they're not getting, they're not seeing their doctor all the time. Coronary artery disease patients have about 40% or less than 40% medication compliance at 6 to 12 months. So people start out okay, and then they drift down and they're not as compliant. There is research evidence that shows that participation in cardiac rehab improves 5-year mortality by 25 to 46%. So that's a good reason for doing cardiac rehab. The American Heart Association cites several studies indicating that non-compliance in coronary artery disease patients with uncomplicated myocardial infarction or stents have a non-compliance rate of over 60%. So 25% of them are non-compliant within a week of discharge. So how often do they see their doctor? Not very often. Cardiac rehab graduates show a 70% compliance rate over 2 years, which is a huge improvement. With beta blockers, aspirin, statins combined for a 20% reduction in 5-year mortality. So really, the cardiac rehab can help build and maintain healthy habits. It can help improve compliance with medications and recommendations from their doctor. So I think that is a really good reason for continuing with cardiac rehab after you're out of the hospital or after you're out of the skilled nursing facility. So if you want to watch this video with cardiac catheterization with an angioplasty, it's pretty interesting. If you like watching surgeries, if we have time in class, we'll watch it, and if we don't, and we will address any questions that you may have in class as well.